Giants of the field of hepatology from the world over speak to you. We are right on time for the next session. I request you all to settle down. It's going to be a symposium on hepatocellular carcinoma. We have exciting speakers lined up for you. I request the honorable chairpersons for the next session to kindly grace the stage. I call upon Sunil Kumar Dadit sir, VG Mohan Prasad sir, respected Dr. Thomas Berg, and our very own Pradeep Padi sir, to please grace the stage with your presence. We're glad to have you here, respected chairpersons. The session for the symposium on hepatocellular carcinoma is all yours.
Good evening. We'll be starting a symposium on SCC. So may I take this pleasure to invite the first speaker, Dr. Raju Sharma from All India Institute of Medical Sciences. He'll be speaking on the clinical course of LIRADS 3 and 4 lesions. Dr. Raju Sharma, please.
Thank you, sir. What I hope to do over the next 15 minutes is take you down LIRAD, especially the category of LIRAD 3 and LIRAD 4, which are somewhat in the gray zone. They are neither definitely benign nor certainly HCCs. And how do we deal with them? So just a brief recap of what
Mic, please. Adjust the mic, please.
Just a brief recap of what LIRAD is. LIRAD is a nomenclature which helps us to grade our probability of a lesion being HCC in patients who are at high risk for developing an HCC, that is patients with cirrhosis, chronic active hepatitis, or with previous HCC, and helps in better collaboration between radiologists, hepatologists, and the pathologists. The modalities for which LIRAD lays down guidelines include sonography for surveillance. There's now a guideline for contrast-enhanced ultrasound. But the one that we are going to focus on is essentially one that combines MDCT and contrast-enhanced MR. The hallmark or the major imaging features that are talked about in this nomenclature for the lesions is non-rim arterial phase enhancement, non-peripheral washout on the venous phase, capsular enhancement in the periphery of the lesion, and threshold growth, which is defined as more than 50% increase in diameter in less than 6-month interval. So these are the algorithms that are laid down by LIRAD. We'll focus on the algorithm based on CT and MR. And remember, we apply it typically in patients who are at high risk of developing HCC. We do not apply it in the pediatric population and also not in patients with Budd-Chiari syndrome. So we can apply it in patients who have these kind of nodules in the liver, patient with cirrhosis, chronic active hepatitis, and with current or prior HCC. In patients who have Budd-Chiari, as is seen in this patient where there's a cavoatrial narrowing, with an HCC in the left lobe, we do not apply LIRAD because these patients are prone to developing a lot of other types of nodules and the sensitivity of imaging is not that high in the diagnosis of HCC. So it divides lesions into categories from LR1 to LR5 based on our degree of probability of that lesion being HCC, from LR1 being definitely benign, progressing to LR5, which is definitely an HCC and does not require histology for the purpose of treatment. LR1 and LR2 are benign lesions where LIRAD gives a list of possibilities where lesions can be placed in this category. So what we do essentially is for LR1 and LR2, which are definitely benign lesions, you have some set lesions which can be put into these categories, which includes liver cyst, liver hemangiomas, based on whether you are definitive about your diagnosis or your level of confidence is less. You can place them in LR1 or LR2. Once we move to LR3 onwards, there is a diagnostic table which is laid down based on the features that I talked about, which includes arterial phase enhancement, the size of the lesion, presence or absence of an enhancing capsule, non-peripheral washout, and threshold growth, and I'll show you examples of this as we go along. There are also some ancillary features which we'll see in the course of the talk, based on which you can upgrade the lesion by 1 grade, but not take it up to the LR5 grade. So these are the two categories that we are interested in, LR3 and LR4. LR3 being a lesion where there's intermediate probability of malignancy. There's almost an equal possibility that the lesion could be benign or be malignant like an HCC. And LR4 is a lesion which is probably HCC, but we are not absolutely sure. So let's look at some examples. This is a patient where there's a T2 weighted image of MR here showing you a brightly hyperintense lesion, peripheral nodular discontinuous enhancement on the arterial phase, and retention of contrast in the more delayed phase. And this is typically an LR1 lesion where you're absolutely certain that this is a hemangioma and it's a benign lesion, can be ignored. This is a lesion in the left lobe of the liver, which is T2 dark. That's a siderotic nodule. And this kind of lesion is placed in LR2. Again, the likelihood of any kind of malignancy is very low. LR3 lesion is one that shows arterial phase enhancement, but does not fulfill the other criteria of a venous washout or the presence of a capsule. And that's when we place it in LR3, that there is an intermediate kind of a possibility of this being benign or malignant. On the other hand, this is a lesion about 9 mm in size on a CT in a cirrhotic patient, which does show venous washout. There's only one major feature which is there in association with arterial phase enhancement, and this is classified as an LR4, where the probability of an HCC is much higher. This is a manifest HCC where you have non-rim arterial phase enhancement, you have venous washout, and you also have presence of a peripheral rim, which is the presence of a capsule. So that's an LR5 lesion. Threshold growth is when the lesion increases in size by more than 50% over a less than or equal to 6-month period, and that's what is highlighted by this, where a 4 mm lesion has evolved into a 1 centimeter lesion, and that's also placed in the LR5 category. When you have peripheral rim enhancement and you have capsular retraction, that's what suggests a mass-forming cholangiocarcinoma, and we place that in LRM. In the interest of time, I'm going to skip the post-treatment changes because that's not the focus of this presentation. So this LIRAD chart gives us what do we do with LR3 and LR4 lesions. An LR3 lesion, which has an intermediate possibility of it being benign or being an HCC, you just need to keep it on imaging follow-up. You may reduce your interval of the repeat follow-up from 6 months to 3 months. And if you've begun with a CT, you may decide to do an MR because that provides us multiple paradigms for lesion characterization. So LR3 needs repeat imaging, which could be at a shorter interval of 3 months than the routine interval of 6 months. On the other hand, an LR4 lesion, where the possibility of an HCC is much higher, is to be discussed in a multidisciplinary discussion, and the management may include biopsying that lesion if it is possible technically. This is a schematic which gives us the differential diagnosis of each of these categories. You can see LR1 is totally filled with benign lesions. On the other hand, in LR3, there's a very small probability that the lesion could be an HCC. And in LR4, there is a much higher probability that the lesion could be an HCC. And this gives us the percentage of HCC and malignancy associated with each of the LIRAD category. And LR3 is placed somewhere here, which may harbor HCC 37% of the times, and 39% it could be malignancy, including the non-HCC malignancies like a mass-forming cholangiocarcinoma. On the other hand, in LR4, the incidence of malignancy could be as high as 74%, and that of malignancy be as high as 81%. So these are the findings for nodules less than 2 centimeters. When they have ancillary features, you can then upgrade these nodules to the LR3 category. Let's look at some literature. This is a systematic review of about 13 studies, and it showed that 9 of these studies conducted LR3 observation level analysis, and the proportion of HCC ranged between 1.2 to 12.5% at a 12-month follow-up. On the other hand, in 9 studies with LR4 observation level analysis, the incidence of HCC ranged between 30 to 44%, and at 12 months that increased to 30 to 71%. The diagnostic value of the ancillary features that have been mentioned in the LIRAD nomenclature. T2 hyperintensity, and a hypointensity on the hepatobiliary phase if you are using a hepatocyte-specific contrast agent yielded the highest level of sensitivity for the diagnosis of HCC. And this study showed that if there is a coexisting hepatocellular carcinoma, and in that patient you are picking up LR3 and LR4 lesions, the incidence of those lesions becoming HCC is much higher. So the presence of a coexistent HCC changes your risk score, which you will assign to your LR3 and LR4 lesions. This is another study which studied the longitudinal evaluation of LIRAD-1 to LIRAD-4 observations, and this is the progression curve where the green one represents an LR1 lesion and the orange one represents the LR4 category and shows that there is a much higher incidence of that lesion turning into an HCC. Let's look at what these features look like. So arterial phase enhancement, which is non-rim type, is somewhat like this. This is a patient with cirrhosis where you have this exophytic type of lesion which shows you heterogeneous enhancement through the entire lesion and not just in the periphery. On the other hand, this lesion just shows you peripheral rim kind of enhancement, which has a different kind of connotation. When we talk of non-peripheral washout, again, washout is studied with respect to the background liver in either the portal venous or the equilibrium phase, and you compare the lesion with the background liver. If the lesion is hypodense or hypointense on MR as compared to the background liver, that's when we say that it is showing a washout. Capsular enhancement is usually seen in the equilibrium phase when you see this peripheral smooth rim of enhancement that is highlighted here with these arrows. That's what suggests the presence of a capsule. Ancillary features, there's a long list of ancillary features that has been laid down in the LIRAD nomenclature. I'll focus only on 2 or 3 of them. The presence of fat within a lesion is taken as an ancillary criteria, which is suggestive of HCC. Presence of restricted diffusion on diffusion-weighted imaging is also taken as a criteria which favors malignancy. And as I mentioned in the earlier slides, we can use the ancillary features to upgrade the category of a lesion by 1 grade. So if you have an LR3 lesion which shows you 1 or more ancillary features, you can upgrade it to an LR4 lesion, but you never take it up to the LR5 category, which is a definitive HCC. So these are some examples of LR2 lesions where you have these T2 hypointense lesions which are T1 bright. They show no enhancement at all on any of the post-contrast images. So this is typically an LR2 lesion. However, if the same lesion started showing you T2 hyperintensity, you would use an ancillary feature and upgrade it to LR3 category. So let's try and apply this to a patient. Here's a CT where you have this very small 8 mm lesion on the arterial phase. It does not show you any washout on the venous phase. We did an MR also on this patient. Again, we saw arterial phase enhancement, but no venous washout. The lesion is in this column because it's 8 mm. It shows you non-rim arterial phase enhancement. There is no washout, no capsule, and you would categorize this as an LR3 lesion, and the management would be to keep it on follow-up and perhaps repeat an MR after a shorter interval like 3 months. Here's another example where you have this small lesion in segment 6 of the liver. It does not show you any washout in the venous or the delayed phases, and this again would fall into the LR3 category. On the other hand, this is a somewhat different lesion where you have a non-rim arterial phase enhancement. You have some washout. You can see that the lesion is subtle, but it becomes hypodense as compared to the background liver. So it's showing you one of the major features, and therefore this can be now categorized in the LR4 category. This would be discussed in an MDT, and if your approach can be decided, if there's a safe approach available, you might decide to biopsy this lesion. Here's a patient which shows you interval growth, threshold interval growth. There's a small lesion which was picked up 7 mm LR4 observation, which is not showing any, which showed venous washout, showed restricted diffusion, and after an interval of 5 months, there was an increase in the diameter of the lesion, and now the lesion had developed clear-cut washout as well as presence of a capsule, and this was a manifest HCC. Here's a lesion which shows you arterial phase enhancement. No washout in the venous phase. There is diffusion restriction. This would have to be categorized in LR4 lesion, but in the MDT discussion, this was thought to be very suspicious for an HCC. They injected lipiodol, and after the injection of lipiodol, this was biopsied under CT guidance. This is a more unusual appearance where you have a hypointense nodule within the left lobe. It's T1 bright. When we injected contrast, There is a small area within that HCC, so this is what we refer to as a nodule within a nodule, and that focus of enhancement, which showed diffusion restriction, would be a focus of HCC within a nodule, within a cirrhosis-associated nodule. This is a manifest HCC with tumor in vein, and if we apply the LIRAD criteria, this is a lesion which is larger than 2 centimeters. It shows non-rim type of arterial phase enhancement, shows venous washout, shows a thrombus in the portal vein, which is distending the lumen of the portal vein. So this would be a tumor in vein, most likely due to an HCC. This is a lesion with peripheral rim enhancement with retention of contrast in the delayed phase, and these features tell us that this would best fit into what we call the LRM category. Most of the LRM lesions are mass-forming cholangios, but occasionally atypical HCCs can also manifest as an LRM lesion. To conclude, LR3 and LR4 observations typically lie in the gray zone where we are not entirely certain. They need to be dealt with very carefully. LR3 lesions are typically kept on imaging follow-up, whereas LR4 observations are to be discussed in a multidisciplinary group and may need to be sampled. Thank you for your attention.
Thank you very much.
Hello.
Thank you very much for such a lucid presentation, sir, on LIRADS 3 and 4 lesions. Now we have the next speaker, Dr. Prasun Jalal, on intermediate and advanced HCC options of treatment. May I request Dr. Prasun to make a speech.
Thank you. I appreciate the opportunity to talk to you all and the organizers for inviting me to be here. So we're going to talk about intermediate and advanced HCC, how do we define it, and what's the subgroups, and what's the strategy for treatment, and the options, especially for downstaging with different local regional treatment, with the evolution of systemic therapy, and with the emerging role for advanced care planning early in the course. So first a case, well, I transported myself to Texas, so an Indian Texan, and we see a lot of metabolic syndrome patients there with Hispanic. Typical profile, doesn't drink alcohol, all the history of cirrhosis is there in the family. And the CAP score, S3, F3, fibrosis, and ultrasound showed just fatty liver. After 4 or 5 years, patient comes with 2 lesions, presented with non-specific abdominal discomfort. If you see 5 centimeter, 2 centimeter, patient doesn't have any decompensation and no metastasis or vascular invasion. So what are we to do? Surgical resection, initiate evaluation for transplant, go with local regional treatment up to downstaging, or go for surgical resection with or without systemic therapy before or after. I can ask the audience, but with the time, we should go ahead. So whenever we talk about HCC management, we always remember this is a disease of the liver, not just a cancer. We look for tumor burden, we look for liver function, and any vascular invasion or metastasis, and most importantly, performance status of the patient. There are different staging systems. TNM doesn't work. It just gives the tumor volume, nothing else. The other staging systems are not externally validated. The most widely used and endorsed, obviously, BCLC, and it's constantly evolving, which is great. Now, that leads to this problem. We can't read anything, and it's getting more and more complex. In 22, there are 3 major changes happened. Number 1, they I know how it is, okay. They included different biomarkers. The intermediate stage, they expanded with 3 substages, and most importantly, they included stage migration because one stage is evolving into another one, especially with different modalities of treatment, which which are constantly evolving. Most important thing about HCC management is multidisciplinary approach. We need everybody. You can sit sequentially or as a team, but if you see the data, that changes the management plan in more than 40% of cases. So it reduces the cost, improves quality of life of the patient, reduces complications, and of course, improves lifespan. So the BCLC staging system is not the best. However, that's what we have. It does not give any information about different combination of local treatment. It doesn't give much information about extensive role for downstaging or resection. And what about radiation beam therapy? And nothing is included there, including expanding role for transplant in various stages is not well defined. So if you see again, let's focus on the intermediate stage. This obviously multinodular, so it's beyond Milan, and good performance status, and no outside spread or vascular invasion. So substage A, B, C, you can say. The A, you go for expanded criteria for transplant. B, you can go for downstaging, and hopefully you can go for transplant. And C, you have got nothing else except going for systemic therapy. There are different modalities here. I mean, we use ECSF all the time, and it's a very good result. I'm not going into details of that. And other staging system is also there in the expanded criteria for transplant. And in United States, it's constantly evolving, and we accept downstage patient for transplant after waiting for 6 months with a higher MELT score. However, there are certain criteria for downstaging. Here, if you see one lesion, 5 to 8 centimeter, 2 or 3, none more than 5 centimeter, and total 8 centimeter. 4 or 5, none more than 3 centimeter, total 8 centimeter. And AFP is very important. If it is more than 1,000, you have to bring it down to less than 500 before you think of putting them on transplant list. So in terms of management of stage B, that's intermediate stage, ASLD kind of says, again, TACE is the primary treatment. Radioembolization, although it's not in the BCLC system, can be used. Then try to do it selectively as much as you can so that it preserves liver function. And obviously, systemic therapy, it don't recommend before or after the moment unless patient has high risk for recurrence, where we can use adjuvant therapy. This is the radiological assessment of treatment response after downstaging the TACE. Typically, after doing TACE, you do the imaging, contrast imaging, after 6 to 8 weeks, even maybe earlier. With a tear or radioembolization, you do later, as 3 months. You do most choose TACE. If there is partial response or no response, move to systemic therapy or other kind of advanced care therapy. Now, what about comparing between radioembolization and TACE? There's not much data. However, recently this one came up, showed TARE is superior to TACE. And if you see here, both overall survival and time to progression improved. So baseline factors which contribute to unsuitability of TACE, primarily in vascular invasion and the more than 50% involvement of the liver. For the tear, you have to look for the shunt, vascular invasion involving major vessel. Refractory, as I mentioned, that after 2 TACEs or 1 tear, if this is progressing or not responding or AFP is not coming down, that's really refractory. Move on to the next one with especially systemic therapy. So that's what the BCLC says. And if you see here, there's nothing there except TACE. So smart people, Dr. Acharya and his team sat down in a nice place in Puri and said, this is not working. We do more LDLT. We need to evolve into other modalities for local regional treatment, including involving TARE or even radiation therapy, or even expanding the criteria for transplant or resection. So that's why you come here. He divided the intermediate stage into 3, 1, 2, 3. And again, as I said, the stage in 1, of course, you go for expanded criteria for transplant, which is widely used. But the change is happening in other ones. So what about stage 2? I mean, within the B, where you're doing here, you are doing either SBRT or TARE in addition to TACE. And similarly, you look for other modalities for far advanced. There is a difference between subgroup 3 and 2. So 3 is more extensive, more diffuse infiltration. But none of these shows any vascular invasion or extrahepatic spread, which moves them to more advanced stage C. So liver resection, now it's expanding. So resection is a treatment of choice in many areas, especially we see that in the data, more than 50% in the worldwide for intermediate and advanced HCC, they're routinely doing surgery in tertiary centers, and none of these are recommended in BCLC. So we have more work to do. And if you see INASL guidelines, they don't care about the size, number, or vascular invasion. All they care about the degree of portal hypertension, and that's important. Patients with clinically significant portal hypertension should not have resection. And this one compared with TACE, and here shows resection superior. So INASL, BCLC stage B, showed that we should go for resection, and also you should use local regional treatment more aggressively. But ASLD still doesn't recommend clearly what you do, and also they recommend against using systemic therapy before the resection. However, after resection, if patient has high-risk behavior, like tumor size more than 5 centimeter and more than 3 tumors, in vascular invasion of any degree or poor tumor differentiation, they should go for atezolizumab systemic therapy after resection as adjuvant therapy. And then you can watch and see whether the patient can be downstage for transplant. What about stage B3? And as I mentioned, systemic therapy is recommended here. However, TARE is also possible based on current evidence, although we need more data. Now, moving on to stage C, intermediate stage, and it has been divided into 2, 1 and 2. So C1, HCC with major vascular invasion is considered absolute contraindication, no doubt. But there is a degree of vascular invasion, which is very important. The patient with segmental or subsegmental vascular invasion, they can be considered the resection or downstaging with TARE or TACE. So this is what shows the patient can be resected if there is obviously no decompensation, clinically significant portal hypertension, even if they have got segmental or subsegmental vascular involvement. What about the external beam radiation therapy? None has been mentioned in any of the guidelines. Now we know that this works, and this has been very important, especially with the location near the vascular areas, major vessels, and there is no size restriction, although most data is up to 8 centimeter tumors. So again, this is from Toronto. They used basically, if you see, radiation therapy in all stages. And these are the trials, although we need more data with randomization. And here, if you see that, that's why we really don't want to stay with systemic therapy alone. We need to include others. Now, when you get stage C2, this advanced stage, then obviously we have to go for systemic therapy alone for now, although it may evolve in future. So here are the systemic therapies which has evolved in the last 10, 15 years with first line and second line. And I'm sure you heard a fantastic lecture from Dr. Sarin yesterday, so we're not going into details of that. The only thing I can say here, with the few minutes left, the first thing, you check the patient's performance status and where do we stand. Is it child A or early B? We don't use this for child C or advanced B. and look whether the patient has any contraindication, any autoimmune disorder, then in that case, you can go for sorafenib and limontenib. Otherwise, go for atazanib beaver. And if atazanib beaver doesn't work, go to Trevor, and then if that, then go for second line, which has tremendous response nowadays with different studies as been shown. So what about advanced care planning? This is a very important issue. We need to involve the patient and the family to discuss the course, because it's a terminal disease, and they need to know better, and they need to know at some point when it's futile and when we need to go to more aggressive treatment. So in conclusion, HCC management guidelines are constantly evolving, and they're very much inadequate. I don't know whether we have a consistent guideline in the near future. However, the silver line is the downstaging is improving, and with effective strategies, resection has been more and more, and we are getting more aggressive in transplantation, especially with LDLT. Systemic therapy also is coming with new drugs with multiple trials, and there is a silver line in the horizon. And of course, we need to involve the family and the patient early in the course with advanced care planning. With that, thank you.
Thank you, sir, for your nice presentation. Next, I will invite Dr. Anand Kulkarni. He will speak on real-world evidence of immunotherapy in hepatocellular carcinoma. Sir, please.
Thank you very much, sir. At the outset, I would like to thank the organizers for inviting me to the beautiful city of temples. And my job has been done easy by Dr. Sharma and Professor Jalal here. So I'll be talking about real-world evidence of immunotherapy in HCC. The approved drugs as per BCLC is two. One is atezolizumab. There's lots of real-world evidence for that. There are around 52 publications on real-world evidence of atezolizumab. But the next one, which has come, Himalaya trial, which was published in NEJM evidence, there is no much real-world evidence for that as of now. So I'll be sticking to atezolizumab for now. So why do we need real-world evidence? There are certain differences between randomized studies and real-world evidence. In the real-world evidence, we don't have any strict inclusion-exclusion criteria. There is wide unrestricted use. There is exhaustive inclusion-exclusion criteria in randomized controlled trials. It's a protocol-based study. We need to have a patient who will respond to therapy, probably a very good performance status patient, and a good child-pug score will be included in RCTs. So this was an NEJM study, which is the magic of randomization versus the myth of real-world evidence. There are several rebuttals written for this, but there are certain lessons which we can learn from the real-world evidence. That's the reason we'll be speaking on immunotherapy's real-world evidence. These are the inclusion criteria in the IM-BRAVE, which was untreated HCC, child-pug A, good performance status. But in our practice, we hardly see any patients who come to us in child-pug A with a HCC and are willing for transplant upfront. These are two studies, one from India, one from US, both saying that patients with HCC, when they present to a clinic, they are either in child B or child C. Hardly 35 to 40% will be in child A. That's the reason we need a preliminary evidence. There was some study, the safety and tolerability of atezolizumab in child-pug A and B, for which there was a letter saying that should we extend the boundaries of this drug. With this background, we'll be discussing one or two interesting cases of our real practice, which we have seen recently. This is a 60-year-old male, NASH cirrhosis, diabetic since 8 years, was evaluated elsewhere, found to have HCC because of weight loss and loss of appetite. Alpha-fetoprotein done there was more than 10,000. He was advised palliative care and sent home. He came to AIG for second opinion. He was depressed. His baseline lab values were good. His bilirubin was 1.2, albumin was 2.9, INR 1.47, but AFP was 23,000. Endoscopy showed grade 2 varices with severe PHG. We got a PET scan done. Huge tumor burden. Everywhere there is a tumor. There is portal vein thrombosis, RPV, LPV. There is a tumor in the bone as well. You can see the picture of that. We have taken the consent of the patient as well. There is a tumor in the ribs. There is a tumor in the pelvic bones. So patient, portal hypertension, grade 2 varices, NASH cirrhosis, mild ascites, CTP7B, not in the inclusion criteria of IM-BRAVE, BCLCC, performance status 1, alpha-fetoprotein 23,000. Should we go ahead with advice in palliative care, or lenvatinib, or sorafenib, or atezolizumab, or liver transplant? Obviously, it's not possible for this patient who has huge tumor burden. So, we decided to give him for atezolizumab. We started him on atezolizumab, bevacizumab. But unfortunately, his alpha-fetoprotein after 3 doses rose to 49,000. From 23, it came to 49. But the tumor in the liver disappeared. There was significant decrease in the size, enhancement, and metabolic activity in the liver. And in the bones, there was significant increase, huge increase in the bones, especially in the pelvic and ribs. We are confused. We had a multidisciplinary team meeting. We discussed with the family. He has 2 children, both very young. We had advanced care planning, as Professor Jalal said here. We had multiple discussions, multiple rounds of discussions. We are confused whether to stop the therapy or continue. Based on the resist and M-resist, they gave us a disease saying that it's a partial response. It's not stable disease, it's not progressive disease, it's a PR. Because the tumor, because the resist counts only for liver, so there was, PR was the reported, which was given in PET scan. So after multiple rounds of discussion, we continued him on atezolizumab and bevacizumab, another 3 rounds. Quite scared we were, and he came back with these reports. Complete disappearance of tumor in the bones, complete disappearance of the tumor in the pelvic bones, ribs, and almost near total complete resolution in the liver as well. So almost that, but alpha-fetoprotein, which was almost nearing 50,000, has come down to 4,500. Obviously, we cannot transplant him because he still has high alpha-fetoprotein, and we need an alpha-fetoprotein less than 1,000 to be eligible for transplant. And there is probably some evidence of METs somewhere which we are not able to find on these scans. This is second case, simple case, 68-year-old, good performance status, not willing for transplant. He is not in any procedures. He has some, some reservations regarding procedures and transplant. Only prominent veins, quite affordable. We started him on immunotherapy. 3 cycles, complete disappearance of tumor. He is very well fitting into the criteria of I am brave, although this is not frequently seen in our practice. But yes, if you have a patient who fits into I am brave criteria, he will definitely respond to immunotherapy. But there are certain questions in these 2 cases which we discussed. One, why did we choose atezolizumab? What is the dosing method of atezolizumab? How long should we continue? The patient has responded to therapy. Should we continue? Should we stop? Most important aspect we look when a patient we decide for a systemic therapy, whether it is age, etiology, Child-Pugh score, performance status, burden of the disease, alpha-fetoprotein, extrahepatic METs, or portal vein thrombosis. Everything counts, definitely. The risk of variceal bleeding, that's the most feared adverse event for any patient who receives bevacizumab. Although bevacizumab has been there in market since 2004, but since it has been approved for HCC for the past 1 or 2 years, we are only worried about variceal bleed and the adverse events related to it. When to transplant after immune checkpoint inhibitors? These are several questions which come to our mind when we discuss about real-world evidence of atezolizumab. So why did we choose atezolizumab? This is the first NEGM trial which said that the response rate, complete response rate is in 10 to 12% compared to the drugs which was used there, sorafenib, which is 1%. So definitely there is almost like 10%, 10 times increase in complete response rate. Why not choose a drug which can give some life to the patient? Same was observed in our study. It was a multi-center study. We and Dr. Karan from Jaipur also had a few patients, and we noted that complete response was seen in 13% of individuals. Of these 8 patients who achieved complete response, 2 had also undergone transarterial radioembolization. Partial response in 25.8%, ORR in 38%, and DCR in 66%. So that's the reason why we choose atezolizumab. What is the dosing method? This is the recommended dosing method, that is 1200 mg of atezo and bevacizumab at 15 mg per kg body weight. We began with such a dosing, but now we have slightly changed our practice to use it at 10 mg per kg body weight. There are few studies in the real world as well saying that 7.5 mg per kg body weight is as effective as 15 mg per kg body weight in patients with HCC. So how long we continue the therapy? The recommended is to continue until the disease progresses. But these are certain studies. The median number of cycles the patient received was 3 to 6. So what we do when the patient achieves a response, we either increase the duration between the drugs, either 30 days or 5 weeks or 6 weeks, because the half-life of the drug is 19 to 30 days. And if the patient has financial problems, which is more often in our settings, we can decrease the dosing of atezo and bev to 500 mg of bevacizumab and atezo 840 mg. So the second patient age was 68 years. So there are 2 studies by the same author, one in Hepatology International and the other one in Liver International, saying that age does not matter. The progression-free survival and the overall survival remains same with the irrespective of the age. Does the etiology matter? Yes, the initial study on IM Brave said that NASH patients respond poorly. There was also a Nature paper saying that the tumor microenvironment doesn't favor using atezolizumab and bev, but this is an updated meta-analysis was published in Journal of Hepatology saying that immune checkpoint inhibitors work well irrespective of the etiology. The same has been noted in the meta-analysis which we have performed. It is under review. The pooled progression-free survival was similar in patients with viral and non-viral etiology. Does child pug score matter? Yes, definitely. As we've seen in the BCLC staging as well, the patient is advanced child C, he is in BCLC D. So, which is what we noted in our study. Child pug A have very good, excellent overall response, overall survival rate of 21 months and progression-free survival compared to child B and child C. There are several of them which have been there in the literature now. The OS and PFS is completely dependent on CTP class. Although few studies say that ALB score also matters, but in our settings, I'm not sure if ALB holds true because albumin, the albumin higher level is 4. So all our patients have albumin of 3.8, 3.9. The patient of 3.9 will directly go into ALB score 2. So we haven't found in our study that the ALB score matters the outcome. There are several predictors of outcome which have been reported in the literature. The one and most important is prior loco-regional therapy. Post radioembolization, there is increase in the tumor antigen presentation. So if you do a tear followed by atezolizumab, then the response rate is much better compared to patients who receive atezolizumab alone. And low alpha fetoprotein definitely has good response rate. NLR ratio, there are various reports saying that less than 2.5 or less than 5 predicts the response to therapy. ALB score, ECOG performance status is definitely required. Performance status should be good to the patient to respond. And ascites also predicts the overall survival. Lastly, this is the last 2 points. What the frequently asked question is PD-L1 expression on the tumor doesn't have any role in patients with atezolizumab. Although the NEGM study has been analyzed again, and they have reported that T cell T effector signature and intratumoral CD8 activity can improve the survival to patients receive atezolizumab. What about endoscopy and banding for all? This was a study, elegant study published in Clinical Gastroenterology Hepatology. 194 patients, only 1 or 2 underwent endoscopy. 8 had bleeding, and the predictor factor for bleeding was main portal vein thrombosis, not the recipient, not the prophylactic EVL as well. In our cohort, we saw 2 patients who had bleeding of 67, one who had a history of variceal bleed. If the patient has history of variceal bleed, avoid atezolizumab, and the patient has main portal vein thrombosis, avoid banding. These are 2 patients who bleed. Common adverse events include fatigue, fever, and myalgia. The cumulative incidence of bleed is around 4.7%, and it's similar between child A and child B, and it is significantly higher if the patient has main portal vein thrombosis. So the prophylactic banding, especially in main portal vein thrombosis, should be avoided. This is the third case, 66-year-old male, diabetic, good BMI of 23.5, had some vague complaints evaluated and found to have multifocal HCC, alpha fetoprotein of 36K. After 3 doses, the disease was stable, but of the 4 doses of immunotherapy, he had a bilirubin which was 8.4, AST, ALT 441, 137, ALP 401. So there are certain unique adverse events which you should be aware with atezolizumab. This is one of them. This immune checkpoint inhibitor related autoimmune hepatitis. We got him tested. He was ANA positive, IgG was 2000, asthma was positive. Started on corticosteroids 40 mg per day. Day 5 there was decrease in bilirubin, decrease in enzymes. Day 14 again further decrease. But actually after 6 weeks again had worsening of the liver function test and is hospitalized currently. So the cumulative incidence of adverse events, immune-related adverse events is noted in 10% of individuals. Commonest is hepatitis, hypothyroidism, rheumatological, musculoskeletal, diarrhea, multiple of them. So if you are giving immunotherapy, be aware that patient may develop immune-related adverse events, which can be treated with corticosteroids, but it is difficult to identify. It usually occurs after 1 to 3 doses, mixed picture of hepatocellular followed by the hepatocellular picture. Steroids plus minus MMF is a treatment of choice for grade 3 adverse events. The commonest drug which is reported to be associated with adverse events, immune-related adverse events are ipilimumab plus nivolumab, although not approved by BCLC. Durva is also reported to have 12% of immune-related adverse events, while atezolizumab around 9%. These are unusual adverse events which we have noted. There are severe oral ulcers which was developed in one of the patients. We had to stop the therapy because of the ulcers, and he had severe pain. The second patient has a severe ulcers over the foot. He had to undergo debridement for this painful ulcers. We also have seen some penile ulcerations. Unusual adverse events are common, but as the therapy, if they respond, they do very well. And of the 2 patients who respond, who had adverse events, most of them are viral related patients. So when you transplant, the data is very good for nivolumab. After nivolumab, 2 to 3 months we can plan transplant, and the risk of rejection is pretty low. But the earlier case report has been reported for atezolizumab. One patient who underwent transplant for liver failure post atezolizumab did not have any rejections after 10 months of transplant. Although we still need more data on this aspect. We have planned 2 patients for transplant on this. So checklist prior to atezolizumab, this is one which I usually use in my clinical practice. Child A or B is good patient for atezolizumab, never C. Good performance status is must not avoid in more than one. Age and etiology does not matter. Endoscopy and varoscopy evaluation is must not, but not banding for all, especially in the patient with main portal vein thrombosis. I don't do banding for patient with main portal vein thrombosis. Start a beta blocker. If you are a fan of simvastatin, you can also start on simvastatin. Check for autoimmune diseases. If a patient is a known bleeder, start only after eradication of the varices. Till then, you can start them on TKIs. And extrahepatic spread and portal vein thrombosis. Who respond better is a common question. We don't know who responds better. The data is not that good. But if the patient has portal vein thrombosis, I would prefer to do a SBRT or a tear followed by immunotherapy. At least 6 cycles are required to assess the response, as we noted here. And if you want to reduce the adverse events and the cost, you can reduce the dose of the drug. In summary, choosing the right patient is the key to successful outcome. And there are trials which are coming with local regional therapy and immunotherapy, probably which is much better, provided the cost increases significantly there. The variceal bleeding is less than feared, but usually fatal. STRIDE is yet to come in India, and we need a lot of data to compare STRIDE against atezolizumab. The only drawback of this immunotherapy is there are unusual adverse events and the cost associated with it. There is a problem with this treating HCC is like an art. Hippocrates said that wherever the art of medicine is loved, there is also a love for humanity. So HCC, if a patient of HCC has multiple options, ranging from local regional therapies to surgeries, transplant, multiple drugs. So each patient is different, each individual is different. It depends on the luck of the patient, also probably the person who is treating it. Thank you.
Yeah, well, thank you very much for excellent talks. Perhaps I would like to first ask whether there are any questions coming from the floor. Yes, please.
What is the data on downstaging, vascular invasion, and taking the patient to transplant?
There is obviously no randomized trial, but depending on, and sometimes we see small tumor with vascular invasion, sometimes a large tumor with vascular invasion. It's a heterogeneous group of people. However, after the downstaging, if the patient responds and the tumor thrombus disappears or stays stable, UNOS gives 1 year time period. And after, so if there is vascular invasion after downstaging, you have to wait for 1 year and then list the patient for transplant, because the whole idea is to reduce tumor recurrence, and the data is pretty good in terms of not having tumor recurrence if there is complete resolution or stable tumor.
Please.
Yeah, thanks. Enjoyed your talk as usual, Anand. Tell me regarding the response to atezolizumab. You have told us what predicts, what all those do's and don'ts. Your checklist was quite nice. But can you tell us who are those patients who will not respond? Because your complete response is 10%, and overall it's about 28 to 30% SD or partial response. So it's probably more important or equally important to identify the ones who will not respond to atezolizumab, because by giving that for 3 or 6 cycles, you're losing time, and if the disease is progressing, alternative options you're running out of with it. And between TKI and atezolizumab, how do you make a choice?
Absolutely, fantastic question, sir. Between TKI and immunotherapy, probably what matters is cost. If the patient is affordable and willing, I would first choice will be atezolizumab. The problem with not to give, we should not give? Child 8B, more than 8B, just avoid it, and bilirubin more than 3, avoid it.
Maybe before we come to the question from the floor, I would like to add, you did not mention decompensation of the disease. Well, we're bleeding as a side effect, and you mentioned other side effects, but I quite often see, and perhaps a side effect due to bevacizumab, that patients deteriorate and get ascites. Do you see this quite often also in the child A status or only in the B7?
2 or 3 patients who had decompensated immediately after first dose. What predicts it, we are not sure, but these are hepatitis B related cirrhosis, and there is no reactivation.
Then you continue on monotherapy with atezo, or do you stop completely? Okay. Yeah, please.
Yeah, thank you. Anand, nice talk. 2 questions to you. One, before starting systemic therapy, would you recommend doing a biopsy to look at the markers like PD-1, PD-L1? And the second question would be, you said patient where I bleed, till various eradication you will put them on TK. Is there any data to say that we can start on atezo alone and then later add on beva?
The first study which was done on atezo alone was published in Lancet Oncology, which showed that the progression-free survival is 3 months. So I am not, a single drug may not benefit the individual, so there is no use. Secondly, if you want to start a patient on TKIs, how long to wait? Eradication is preferred. If the patient is a bleeder especially, then till then we can start on TKIs. That is my opinion, sir.
And what about biopsy? Biopsying patient prior
no,
to...
sir. This was published recently. There is no role of biopsy for starting these PD-L1 inhibitors.
May I ask to Dr. Jalal, where do you place the, is there any role of a combination of treatment?
Combination of, you mean combination of TACE, TARE?
Yeah, and combination of LRT versus systemic.
So I kind of mentioned about the resection part. At the moment, no guideline recommends the combination of systemic therapy with LRT. However, the trials are going on, and I'm sure that in future it will be incorporated. But at the moment, the guideline does not recommend it.
And at the current position, where do you place the role of SBRT?
So SBRT, I mean, the external beam radiation therapy, it could be proton beam or SBRT, is very interesting. And I kind of mentioned it, that is underutilized. It should be used more often in intermediate and even advanced. The key is the patient need to have good functional liver. The size doesn't matter, although most data is with the tumor size up to 8 centimeter. Especially when the tumor is located in major vessels or major organs. So SBRT is very useful when you can't do TACE or TARE, or patient did not, although this is not data driven, but when the patient failed TACE and TARE, people have done SBRT. So it's underutilized and it has huge potential.
Wonderful talk, Dr. Anand. I have a question for you. Like when you're using the immune checkpoint inhibitors, like we also have 2 patients on atezo-bev and they're responding so well, so interesting after a long time. My question is, do you try TACE or TARE before going in for immune checkpoint inhibitors, and what is your experience in that?
So we have around 6 patients, 4 of them were part of the study. Of the 4 patients who had TARE followed by immunotherapy, 2 have complete response, 2 have partial response, and they are doing well. So if feasible, combine both of them.
So you would recommend in all cases?
If the patient has portal vein thrombosis, large tumor burden, willing for financially okay, then yes.
I mean, to answer that question also, if you see in the guidelines, BCLC, in stage B, you first, in B2 or in the intermediate stage, first you do TACE, and then you go for systemic therapy. The main question is whether you combine them together. That data is not there yet.
Yeah. Well, perhaps you can continue on that, but first there's a question coming from the floor.
Yeah, my question to Dr. Anand. Is atezo-beva safe to use in someone who has presented with HCC tumor rupture? If you have controlled it with transarterial embolization, and if yes, then after how long after that episode can you use it?
A lot of interest in systemic therapy, right?
So if the tumor has ruptured, probably TACE is the best therapy.
Now,
And
after you have done a transatrial embolization, the bleeding
either
has stopped.
atezolizumab or lenvatinib. There are reports with lenvatinib causing tumor rupture. Either both of them have a risk of tumor rupture.
Okay.
Given a choice to me, I would prefer a tyrosine kinase inhibitors.
I think we should ask Dr. Sharma also a question about the LIRAD system. I would be interested personally also what is how it is performed in India. So do you get regular LIRAD results on your documents if you send a patient to the radiology or ultrasound department? So will they classify?
So I think there is acceptance in the tertiary care centers. All the tertiary care centers follow it.
So you get it normally, but mainly this comes from CT or MRI, or also when it comes to ultrasound? Or do you always use contrast-enhanced ultrasound?
No, the use of contrast-enhanced ultrasound is very limited. There are only very few centers in the country which are using contrast-enhanced ultrasound. It's primarily on CT and in the tertiary care centers, increasingly with MR.
So then what is the indication for this index, CT scan or MRI, to classify the patient? So why they got a CT scan in the beginning?
For surveillance.
For surveillance, yeah. And which patients do you survey with CT or MRI?
I would let the hepatologist answer that.
Yeah. I think most of us would use CT. And if there is a doubtful lesion only, we have a comparative MRI to superimpose. But most of us would use CT. And I'm sure many of the centers, almost more than 70-80% of radiologists give the LIRAD score now.
Yeah. So. And if you have an unclassified nodule on CT, then you go for an MRI with a EOB?
That's right. We use, EOB is not available in India.
Okay.
We use multi-hands. So gadobinate is what we use. We do not have EOB in India at all. And we use MR more, as you said, as a problem-solving technique. If you're not able to characterize something on CT, then we'll go ahead and do an MR.
Okay, there are more questions from the floor. Yeah, please.
Yeah.
Yes,
See,
question for Dr. Jal.
Please.
Patients with hepatocellular carcinoma, you just mentioned surgeons are very keen on resecting them, which is good because this is a curative treatment. But what can happen at times that when they resect a segment of liver, particularly in a cirrhotic patient, there is a risk of getting into hepatic decompensation, which could be lethal at times. So what's your say on this?
So again, we have to be careful. The most importantly, selection of patient. They should not be having clinically significant portal hypertension and need to have at least 40% of future residual liver in cirrhotics. So case selection is very important. Still, decompensation can happen, and that's why you have salvage transplant. You need to keep that. But however, I can say that most of the resections probably happen in Asian countries compared to European or American. The transplant is still the best option in those countries.
Thank you.
Okay, question from the floor.
This is a question to Dr. Anand. See, out of your whole lot of patients, only 3 decompensated?
Yes, sir.
How many had ascites at baseline?
We usually prefer not to take moderate to severe ascites for immunotherapy or TKIs. Mild ascites is definitely, at least of the 127 patients data which we have, around 50 to 60 have had mild ascites.
So if there is a grade 3 ascites, you don't?
No, usually
okay,
don't.
Thank you.
Can I ask one? Yeah, we have contrast endoscopic ultrasound in our department. When we use it primarily in patients who cannot undergo a CECT, that means those with raised serum creatinine. In fact, we get it so infrequently done, but most of the time our radiologist or ultrasoundologist has to bank upon other ancillary investigations. And whenever you have raised serum creatinine, you cannot do a CECT patient as a large SOL with raised alpha protein, that becomes the first indication for HCC. My question is to Dr. Anand. You have had so many patients being treated. The biggest problem with the atezolizumab and bevacizumab is the cost. Can we request the company to split the cost into 3 parts? What they do is that upfront they take the cost of the first injection, which is humongous, about 5 lakh Indian rupees, and then split into 3 parts. So why not have individual? Because some of these patients may not be good enough to last for a few months.
Sir, I represent AIG. I have the same concern as you. And my request to the company guys, if they are here, is the same.
And the question is about a young man of the 53 years, had a large HCC and followed by the resection. He was compensated having the cirrhosis on operation theatre, and thereafter he decompensated. And after the decompensated, and he was managed according to the ACLF kind of a thing, and he recovered now. Do you recommend, can we use atezo and the BAV in this patient, or is it a contraindication for further systemic therapy?
Sir, as of now, the IMRAV 050, which has come post-resection, we can use atezolizumab. The patient is compensated cirrhosis. If the patient is well compensated after has resolved, probably if it is affordable, we can start him, sir. It is a prophylactic therapy which has come now.
So if he becomes compensated after, so we can use it?
Yes, sir. Yes, sir. That's what IMRAV 050 is, but the feasibility in India is quite difficult.
So, after recompensation occurs, you will not wait for 1 year?
Not as such. If the patient is doing well, his performance status is good, we'll start.
Sir, my last question is to Sharma sir. Sir, if lesion is LR4, which indicates probable ACC, so how frequently you go for surveillance to know the progression of the lesion? How frequently you go for surveillance?
No, we would discuss it in a multidisciplinary team, and if the lesion is amenable to biopsy, we would suggest sample it. That cannot be put in the surveillance line. It would have to be dealt with more aggressively, and if it is amenable to biopsy, we would certainly say biopsy it.
I think we have to close the session, but there's one final question from the floor I think we can take.
If there was a patient with systemic spread who is now transplantable, is there a minimum time span which we have to wait or assess, or we can take him for transplant straight away?
3 months is the preferred washout period to have the lesser incidence of rejections. 3 months is preferred. 3 weeks to 3 months. But there is no hard and fast rule.
The data is still not very good. We had almost 30% rejection post-transplant in some of the studies.
Kimberly Watt was saying 3 months is the preferred duration between immunotherapy and transplant.
Okay, we have to come to an end of the session. I would like to thank very much the speaker for excellent talks and all the chairmen, and thank you for joining.
Now we know what it feels like to hear to some of the brightest minds. There was an interesting session. The symposium on HCC comes to an end. We are now scheduled to have a general body meeting of the INASL Governing Council here. Ladies and gentlemen, I ask you to settle down, and we'll be starting shortly.